my group mates. My name is Maputi Siyema, and we have decided to outlay our presentation as seen on the slides. We were given a task to discuss the extent to which the fixed dose combination of pyronardine tetraphosphate and artesunate, which we know as Pyramex, meets this target product profile. In our discussion, we were also asked to include the key information about Pyramex and the epidemiology of the disease in an African setting and globally. Malaria is a severe disease caused by parasites of the genus Plasmodium, which is transmitted to humans by a bite of an infected female mosquito of the species Anopheles. And it consists of several subspecies, commonly the P. vivax and P. malariae in America and Europe, while in Africa, the Plasmodium falciparum dominates. Most cases occur in sub-Saharan Africa, and in Asia, Latin America, and to a lesser extent, the Middle East and parts of Europe are also affected. Malaria is one of the most concerning vector-borne infections in sub-Saharan Africa, especially in tropical regions, which account for 90% of all malaria-related death. It also poses a risk to approximately 3.3 billion people, or approximately half of the world's population, and it's the third largest killer of children between the ages of 1 month and 5 years. Globally, there were 249 million cases in 2022, which was an increase of 5 million as compared to 2021. And this increase was mainly concentrated in 5 countries, which have been named there. And the number of lives lost to malaria declined marginally in 2022 versus in 2021. 76% of global malaria deaths were in children under 5 years old, which is more than 1,000 children dying of malaria every day, mostly in our continent of Africa. And 94% of cases and 95% of deaths were in the WHO African region. The cases of malaria, which have been averted globally in the years between 2000 and 2022, were 2.1 billion, and the deaths that were averted in the same period were 11.7 million deaths. And this is showing in this time an upward trend, meaning that the cases have been increasing in the time that has been depicted there. And what we've just talked about and seen on the slide is explained here in the next slide. And in our African region, globally, in 2022, we accounted for 94% of all malaria cases and 95% of the deaths. And in 2022, 4 countries in the region accounted for nearly half of all the malaria cases globally. And in 33 moderate to high transmission countries in the WHO African region, there was an estimated 35.4 million pregnancies, of which 12.7 million were exposed to malaria infection during the pregnancy. Malaria cases by country in the WHO African region in 2022 are shown as the charts depicted here, and South Africa as a region is not flagged, as you can see on the chart.
So just to continue, if we have to look at epidemiology in South Africa, we have it mainly found in 3 provinces, Limpopo, Mpumalanga, and KwaZulu-Natal. The vector mainly responsible is the female Anopheles, which branches into 2 species as seen on the slide. South Africa has recorded over 7,400 malaria cases between January and October in 2023, with only 17% of these actually being locally acquired. Most of these people have traveled abroad to endemic regions and then acquired the malaria. Gauteng hospitals also reported a low number of cases and deaths from January to September 2023. Our current treatment in South Africa includes, after confirming diagnosis and assessing severity, you then determine if it's uncomplicated malaria or severe malaria. If either or, depending on the species known, you can either give the patient mether, a combination of lumefantrine, which is also known as coartem, or if that's not available, you can do oral quinine, either with doxycycline or clindamycin. As you can see from this presentation of South Africa, we do not have Pyramax that's available. So unfortunately, in terms of efficacy and resistance, the emergence of resistance to artesunate and partner drugs poses a great risk to the global effort to reduce the burden of malaria. We also have partial resistance, which have been spread across the globe in areas of Cambodia, Thailand, Vietnam, and then, of course, in the African region. Such as Rwanda, Uganda, and Tanzania. They also have resistance of monotherapies, and therefore there is a need for new medication without resistance. Climate change also causes and contributes to the malaria rate. It affects the livelihoods, increasing the risk of harmful exposure to particulates, pathogens, and disease, therefore overburdening our health systems and widening existing inequalities. Vector-borne diseases are driven by environmental and climatic factors, making them sensitive to climate change. We have a worldwide crisis and biological threats that also cause an upward trend in malaria cases. So as we know, in 2019, we had the COVID-19 pandemic, and 41 countries also suffered worldwide crises of and health emergencies such as tornadoes, flooding, etc. And then, of course, the COVID-19 slowed down the rate of cases because all of the world was contributing to the COVID-19. We also saw trends in Ethiopia, as well as political and social instability in MENA, which then also led to neighboring countries having a rise in malaria cases. And then if you're looking at biological threats, these include parasite resistance to medicine, resistance to insecticides, genetic mutations, as well as the spread of new malarial parasites and mosquito vectors. So the drug of choice or at hand, Pyramax is a new fixed dose combination of pyronidine, tetraphosphate, and artesunate, and it's indicated for acute uncomplicated malaria infection caused by the Plasmodium falciparum. We'll go further into detail for the doses that are available and the dosages, but just the CHMP gave a positive scientific opinion on the Pyramax, and Article 58 of regulation was implemented into the European Agency to stimulate the development of medicines and vaccines for low and middle class countries.
Target product profile. The purpose of the TPP, it is a strategic development process tool, which is prepared by a sponsor and then shared with the relevant NRA. The TPP is organized according to the key sections of the drug labeling, and it links drug development activities to specific concepts intended for inclusion in the drug labeling. These are the key sections in the drug labeling, and additionally, patient counseling information is usually done in a separate document, which is known as the Patient Information Leaflet, or the PIL. Pyramax is available in two formulations, which is a film-coated tablet as well as a sachet. With the tablet, it's given in adults and children weighing more than 20 kg, and the sachet is given to children weighing more than 5 kg but less than 20 kg. With the posology, it is taken orally. With the dosing in special population, there's no information on dosing in patients with hepatic impairment. However, it is contraindicated in patients with signs of hepatic impairment or a non-significant liver function test abnormalities. There's no information on dosing patients with severe renal impairment. With the contraindications, it is contraindicated in patients with a known hypersensitivity to any of the APIs as well as components, and also contraindicated in patients with clinical signs or symptoms of hepatic injury, as well as patients with severe renal impairment. Special warnings and precautions for use. Paramix tablets should not be used for malaria prophylaxis. The same goes for the sachet. There's insufficient data available for patients with co-infections with HIV. And there's no specific QT and QTC study to assess the cardiac safety of Paramix. With the drug interaction, there is interactions when Paramix is co-administered with drugs known to be associated with mitochondrial toxicity, such as valproate and antiretroviral drugs. And also, agents such as digoxin and dabigatran also showed interactions in clinical studies. There was also an interaction with enzyme-inducing medicinal products such as rifampicin, carbamazepine, phenytoin, as well as St. John's wort. With fertility, there are only limited data on the use of Paramix in pregnancy. Artesunate is a known teratogen. However, pyrrolidine did not show any teratogenic effect. There's limited amount of data from the use of artesunate during the first trimester of pregnancy. Artemisinin compounds cannot be recommended for treatment of malaria in the first trimester of pregnancy. With lactation, pyrrolidine is excreted into breast milk. With fertility, there were no effects on fertility in animal studies. With effects on ability to drive, there are no studies on the effects of ability to drive and use medicines have been performed. The side effects have been highlighted in the table below, but they are not limited to the ones listed. In case of an overdose, symptomatic and supportive therapy should be given as appropriate, and AST and ALT should be monitored. How Paramix works is that it leads to parasitic death. With the pharmacodynamic effects, pyrrolidine efficacy studies in rodent models of malaria using sensitive and resistant parasite strains have shown enhanced therapeutic effect using a combination of both compounds in a 3:1 ratio respectively. Artesunate did show potent in vitro activity against multiple strains of P. falciparum as well as P. vivax. With the cross-resistant, pyrrolidine and artesunate were active against P. falciparum strains and isolates that were resistant to other antimalarial agents. With the pharmacokinetic properties, there's no pharmacokinetic interaction between pyrrolidine and artesunate. With the absorption, these peak plasma concentrations are generally reached between 0.5 to 1.0 post-dose for artesunate and between 1 and 2 hours post-dose for DHA and between 2 to 8 for pyrrolidine. With distribution, it is distributed extensively into tissues, and the plasma protein binding is 92 to 95% for pyrrolidine and 62 to 93% for the artesunate. With the biotransformation, it is mostly excreted through the fecal route, even with the elimination as well. And hepatic and renal impairment, Paramix has not been studied for efficacy and safety in patients with severe hepatic and renal impairment. With the elderly patients, there's no specific pharmacokinetic studies that have been performed in patients older than 65 years of age.
The table being illustrated projects the parameters to be demonstrated for the combination of new anti-malarial medicine in a clinical evaluation. So the extent to which the fixed dose combination of Paramix meets the anti-malaria TPP is as follows. In terms of the therapeutic indication, it has demonstrated that it's able to work it's effective against the strains of the P. falciparum and also the P. vivax. And also it's actually indicated in adults with the weight of above 20 kilograms and children. And also there are granules for children who weigh between 5 and 20 kilograms. In terms of efficacy, it has shown that it is potent against multi-drug resistant strains. Also, in terms of efficacy, in phase 3 clinical studies, in both per protocol and also the intent to treat populations, Pyramex has demonstrated that it is non-inferior to artemether, and also in combination with lumefantrine and also mefloquine in combination to artesunate. So in addition to that, 95% of the PCR was corrected in a per protocol population on day 28, showing that it is actually non-inferior to the standard care. The duration of treatment actually it's 3 days, which is the minimum ideal requirement for in terms of the parameters. Also, in terms of the granules, also they are actually indicated for a duration of 3 days, only being taken once daily. Key features that were actually identified was that Pyramex is the only artemisinin-based combination therapy approved by a stringent regulatory authority for both the P-falciparum and P-vivax in the plus stage. So also another again was that there are no food restrictions that were indicated, since that malaria normally causes loss of appetite. And also with it has shown that the shelf life of Pyramex is 2 years, which also shows that it does meet the minimum requirements. In terms of what the gaps identified, the first one is in terms of first pregnancy, that it cannot be used in first trimester due to it being embryotoxic and teratogenic in terms of the artesunate molecule. Also, in terms of the hepatic impairment and also the renal impairment, there isn't enough information to substantiate its use. In terms of HIV and TB, there are no information actually available, which is also a red flag for SA, because these diseases are actually prevalent in South Africa.
The WHO is of the view that there's a critical need to fight against malaria. This requires increased resourcing, stronger political commitment, data-driven strategies, and innovative tools. The innovation should not only focus on efficiency, but also on developing products that are effective and affordable. The WHO recommends the use of artemisinin derivatives for combination therapy where P-falciparum is prevalent to reduce the risk of resistance. The disadvantage of using artemisinin derivatives is reduced by adopting a combination regimen with an agent of a longer half-life. As articulated in the previous slides, Pyramex has a longer half-life, therefore in line with the WHO recommendation. Pyramex is not registered in South Africa as previously articulated, even though it is WHO pre-qualified. While the cost of Pyramex could not be established in South Africa, it was noted that the financial cost per severe case of malaria fell within the range of $30 and $200, and this range was not applicable in South Africa, as South Africa reported higher costs. EMA granted market authorization for use outside of the EU community using the EU for all procedure, and the data that was submitted to EMA was sufficient. However, the condition of registration was that the applicant should keep submit and keep an RMP. Given the information presented, Group 1 recommends for SAPRA to consider granting market authorization using the abridged review pathway, since Pyramex is pre-qualified by the WHO and EMA has granted that positive opinion. When granting marketing authorization, though, SAPRA should request for unredacted reports where they can establish if the population sampled covers the South African population in view of the burden of disease, as South Africa has a high prevalence of HIV and AIDS, TB, and these patients are usually have a compromised liver function. Also, South Africa has a population that uses African traditional medicine, so we would want to observe if Pyramex does not have any drug interaction with the traditional medicines. And because of these factors and the gaps identified as per the previous speaker, SAPRA should also request for a risk management plan as a condition of registration and periodic safety update reports. And countries in the SADC region access health services in South Africa is in conclusion, but also SAPRA is a recognized regulatory authority for other African countries. And as such, registration by SAPRA of Paramex could enable access by other African countries with high prevalence malaria to a product that is effective, efficient, and affordable. And our next slide talks about references, and thank you.